We still don't see that many cases. We try to advocate for it. The law prohibits it, unfortunately, from serious violent felonies, and the list in the IST statute includes things like aggravated assault and things like that, so many people are not eligible for outpatient civic commitment. The commitment may be for a one-year period, and it doesn't have to be for a one-year period. It can be up to a one-year period, but generally, most courts write it for a year period. It has to be renewed every year and has to be looked at by the court every year. This is something we changed in the IST statute a few years ago because people were staying in the hospital real long periods of time and no one was reviewing their case. So the statute says the court has to review the case annually. We often have difficulty getting hearings for that. That's one of the things when we talk about having lawyers. We're looking for lawyers for our defendants because our defendants really need a full hearing to look at, do they still need to be in the hospital? The court may commit a nonviolent felony to the maximum of that crime, their most serious crime, or 5 years, whichever is less. For serious violent felonies, they can do it to the maximum of the most serious crime. And we do have people in our hospitals who are ISTN for 15, 20, 25 years. When the court holds a civil commitment hearing, the criteria is the basic mental health aid that they are supposed to decide if the person meets the criteria. So they have to be mentally ill, and they have to be a substantial risk to themselves or others, or they have to be unable to care for themselves, that they create an imminent life-endangering crisis. I did a study maybe 8 years ago. This all comes from Jackson v. Indiana, which says if you're going to hold someone, the purpose that you hold it for needs to match the commitment. So if you're holding someone on a civil commitment, it needs to match the civil commitment code. When we looked in Georgia, we had lots of people who probably did not meet 37.3 if they went through a probate court, but they did if they went through a superior court. And that piqued my interest, so I did a survey of the other states and found probably 7/8 of the states in the United States have a way of going around Jackson v. Indiana to hold people who would not, if they just walked into a probate court, get civilly committed, but because they have a criminal history and because they did commit usually a significant crime, they are civilly committed under the civil commitment statute that applies to anyone. And the way most courts do it is that the threshold's a little bit higher to get released and a little bit lower to get committed. And the reason for that is that same court has probably seen that person on a murder or aggravated assault charge. So it's a little bit different than a probate court. So when we, DBHUD, make our recommendation to the court about should this person be civilly committed, we hold a meeting with all the treatment staff that work with that individual. That includes the psychiatrist, the nursing staff, social work, activity therapy, psychology, and the individual themselves. And we talk about their risks to the community and to themselves. And we come up with an opinion based on that meeting. And the meeting has looked at the person's behavior over the past year, as well as their history and past risky behaviors. One of the most critical elements in this meeting that we review is a risk assessment. So I want to take a few minutes to talk about how a hospital does a risk assessment. When we do a violence risk assessment, we're looking at the person's potential for violence, which is actual, attempted, or threatened infliction of bodily harm on another person. When we say we're doing a risk assessment, it's important to emphasize that it's a risk. So we don't know for sure, and we can't be certain about what's going to happen. That's why it's a risk assessment. But we're doing it as an assessment, means we gather all the data that we can in order to make this judgment, this uncertain judgment about this person's potential for violence. There's 3 ways generally of doing a violence risk assessment. In the past, it was just professional judgment. A psychiatrist or psychologist reviewed the data and said this person's dangerous, this person's not dangerous. Over the past 20 years, a lot more research has been done in risk assessment, and they realize that clinicians just doing that on their own are not very reliable, and they tend to base information just on their own biases or on the most recent behavior. So 2 different methods came about within the last 20 years, which is an actuarial method of risk assessment and a structured professional judgment. Actuarial method is where you take certain factors and you get a score on it, and then you have a total score, and that total score tells you how risky you are. They use that a lot in classifications in prisons, in a lot of criminal justice settings where you just need to classify people. It doesn't work real well in the hospital setting, because telling you this person is 70% more risky than the next doesn't tell me, should I release this person, or how can I help this person? It's just a number, and it just places you in a risk compared to another normative sample. So what we use in the hospital is called structured professional judgment. And what that entails is making sure that everybody uses the same factors to look at, and these are factors that have been proven through research to be the best practices, the most shown factors to impact violence. So everybody, we at the State Hospital use something called the HCR20. So it has 20 factors, and so we look at all our individuals on those 20 factors. But instead of coming up with a score, we come up with a conceptualization of their individual risk. So what we're asking our psychologists to do is go through the person's history, go through their behavior at the hospital, look at these 20 factors, and based on these 20 factors, give us a conceptualization of this person's risk. The reason we want this rather than a number is then we will know how to treat them. We can't treat a number, we need to have a picture of their risk. And so what we look at is what's the nature of the hazard? Is this person likely to kill somebody? Is this person likely to threaten somebody? Is this person likely to run around naked? What is the nature? How serious is this risk? How likely is it to occur? Has it happened 20 times in the past or only once? Does it happen only when the person's using substances? Does it use it only when they're with their family? So what they do in the risk assessment is really review all incidents, looking for certain factors that seem to occur together when the person's behavior is violent. Frequency and duration, the seriousness of the consequences. If we're worried about murder, it's very, very serious. If we're worried about robbery, not so serious. So what's the risk? And imminence. How likely is it to happen in the future? Of course, as everybody knows, the closer, we can predict better into the next month, next 2 months. Can we predict the next year, next 5 years? The further you go out, the harder it is to predict. With structured professional judgment, instead of predicting, we're trying to prevent, and that's a big difference. When you're doing actuarial risk assessment, you're trying to predict someone's dangerousness. We are trying to prevent the dangerousness. So by conceptualizing what makes this person risky, we can focus our treatment on those particular factors. So what we do after we civilly commit someone is we then do this risk assessment. We present this conceptualization of what we believe makes this person risky, and then we base a treatment plan for that individual on that person's risk factors, which may be different from somebody else on that unit with the exact same crime. So 2 people may have murder charges, but one's may have to do with substance abuse, one's might have to do with depression and other things going on. and therefore the treatment plans will not look the same. So what we do is we identify the target behaviors. So it may be mania, it may be depression, it may be a lack of social skills, and then we design the treatment plan to focus on those particular behaviors. Some behaviors need to be increased, some behaviors need to be decreased. And then we develop treatment strategies to target those behaviors. One of the things we really try to work with our treatment teams is to use the person's strengths when you're designing these treatment plans. And then, once the person has made some success, we want to test that out in the hospitals. So we want the person to have privileges, to walk on. If the person had a very aggressive incident, we want them first to show that they can do things on our campus. You don't want to release someone from a locked unit into the community. You want them to be able to show that they can be responsible on a campus, then out in the community. So for very serious offenses, we often do graduated experiences to see that the person can handle that much freedom, if that is their issue. For some people, that's not their issue,